And I'm going to be talking to you today a little bit about our experiences over the last, I guess, 15 years or so in working with people following terrorist attacks. Just to give you an idea, I'm coming from Israel, and I spend some of my week in academia, in a university in the middle of the country. But the rest of the time, my clinical work is based at Hadassah Hospital, which is just south of Jerusalem. And over the years of around 2000 to 2005, 2006, then what we found was that many terrorist attacks were brought to to our center. It's a level 1 trauma center. And over that period of time, there were more than 2,000 terrorist survivors who were brought in, which gave us a pretty steep learning curve. For the last number of years, we've been less treating terrorist survivors and more concentrating on what normally comes through the hospital, which is motor traffic accidents. But in the last few months, then things have changed. These are some pictures from more recent pictures. And in the last 3 months, then these are the numbers of terrorist incidents. They're sort of too hard to contemplate, I think. But we're talking about, over a period of about 100 days, a couple of incidents a day. It's changed how we're working in many respects. Now, these are slightly different to the slightly different population to the ones we were treating 15 years ago in terms of the physical injuries. Physical injuries, when you have a bomb going off, tend to be, obviously, you have more people who are directly affected, and so more people are coming through, so the numbers we're seeing are not comparable to the number of actual attacks, but it means that it's a constant daily terror, and that is affecting things. So I'm going to start off by talking about PTSD following terrorist attacks. I'm going to try and go pretty quickly through those slides that we've already heard about from Chris Brewer, and I don't want to repeat too much. But I think this quote from Zimbardo is quite important. It's that terrorism really is all about psychology. It's all about not knowing when something's going to happen and when it's going to affect us. And in some ways, it therefore becomes an even bigger problem than other traumatic events that maybe affect us more frequently, but have less of an impact. So, as we've already heard, then the percentages of people who are affected depends on your proximity to the event. Again, substantial stress is something we see in a large percentage of people shortly afterwards. This decreases over time, and the amount of PTSD that we see over a large group is also slightly elevated in the general population. The closer you get, the higher the percentage of PTSD you're going to find. So this doesn't really matter where you are in the world, you see pretty much the same numbers. And so one thing I'd just like to add, though, about what we've noticed happening in Israel, which is that you have to make a distinction between symptoms and psychopathology, especially in a period of ongoing terror. And I think this is probably true of many places in Europe at the moment. When something happens, you change your behavior. You change your behavior because the level of danger has objectively changed. And those things are often confused with PTSD symptoms. So we have many people at the moment who are maybe not going out as much as they would be. They're avoiding certain places. That there are certain areas that they wouldn't travel to. They don't feel the same, they're not as excited about going out, and they're thinking about what's been happening. And when you give them a PTSD questionnaire, they score pretty highly. However, when you then check their levels of functioning, you see their levels of functioning are also very high. They remain very high. And so sometimes you have to have a look at these levels of stress and see them with a slightly different eye, and not necessarily assume that every type of symptom is definitely psychopathology. It may be a normal, natural, and good reaction to what's going on around you. And that's certainly something we see. But overall, wherever you are, pretty much being close proximity to terrorist attack, you're going to see around the 30-35% PTSD. further away it reduces. We did a comparative study on the same population, people coming to our emergency room, some after a terrorist attack and some after a traffic accident. And what you find is that PTSD is PTSD. The rates here are higher, double than after a terrorist attack, but after a terrorist attack than after a traffic accident. But probably, again, this just reflects the fact that these are more difficult events, and therefore you would expect to see more PTSD. But the PTSD itself looks the same in terms of the symptoms that you see and the trajectory that you see over time. So I'm going to bring a different perspective, I think, slightly to treatment and what we've learnt about treatment. I'm starting off with this quote from Cy Weasley that brings a little bit of the cynicism in, that says, why do we need to do anything at all? I'd just like you to keep this question in mind as we go through, because I think, we're all here because we feel that there's a need to do something, but I think it's important to question exactly what it is that we want to be doing and how we want to be doing it and why. So when we talk about early interventions straight after an event, then there are different aims that we might have in mind. The first one, which it seems to be obvious, and this is generally what pervades the literature, is prevention. That possibly we can do something early on that will help reduce that trajectory and prevent PTSD from developing. It's possible, though, that if we're talking about very early interventions, that we really should be thinking more in terms of symptom reduction at the time and less in terms of prevention. And, of course, we don't want to cause harm. And we also have to have an idea about our outcomes, because we often talk about reactions to terrorist attacks and reactions to trauma in general in terms of PTSD. But as Chris mentioned, and I'm going to bring a little bit of data on this as well, PTSD isn't the only reaction that we see, so possibly we need to be thinking in terms of other psychiatric disorders. And, of course, there's an issue of quality of life in general. We may not be impacting directly on the psychiatric disorders, but we might want to be looking at quality of life. And clearly these two things are connected to each other. So when we talk about very early interventions, then we can divide it in time-wise between the first hours, the first days, and the first weeks. I'm going to talk just very briefly about the first two and spend most of my time about the last one because we know more about it. But I think the first ones are quite important, especially when you're planning services, because those first hours are generally when people are only just beginning to think about what's happening, but you may need at that point to already be providing services, and that requires planning beforehand. So when we're talking about the first hours, then it's a rare experience for most mental health professionals. I don't know, we don't have much liaison psychiatry in Israel, so most people working in mental health sit in an office and have people come to them. When you're working in an emergency room or a different type of environment, but an immediate environment after an event, then it's very different. You're going to them, you're going to talk to them. What we have at Hadassah Hospital is an extremely organized response from, first of all, the social work department. They have people who are on call anyhow and then bring in other people as and when are needed. And their response is divided into, on the one hand, what's called the family room, where they have an immediate computerized list of anybody who's been brought in. Now, some people who've been brought in are conscious, and everybody in Israel has an ID number, so just overcoming some of the problems that Chris was talking about earlier, it's very, very straightforward to figure out who these people are. But it's a computerized list through all the hospitals, so there's more than one trauma hospital in the area. It means there can be communication, which means that they can put family members, for example, back together, if one was taken to one hospital and one to the other. People who come in either not conscious or without identification, then one of the first priorities for this team is to help work out who these people are and matching between people who are, you know, phoning distressed relatives saying, you know, my 19-year-old son, you know, hasn't come home and he was on that bus. What's happening, to the people that aren't clear. And it's many hours of very intensive work at the beginning, matching everything up. I think it's extremely, extremely important, though, because the distress that you see a lot at the beginning for people is that they don't know where they are, but they certainly don't know where their loved ones are. And anything that you can do to mitigate that is very important. And apart from that, then, they check every single person and see how they're doing. Often it's just a matter of normalization and giving them information about further referrals, but they also work in liaison with psychiatry, so that we will go in and see people as and when are needed. It depends on the type of event. If it's a mass casualty event, we tend to go anyhow because the numbers are just too overwhelming for one department. But otherwise, we would go in as and when is needed. Again, that's something that requires planning beforehand. We have teams that are set up, you know, people who are who are the first point of contact. So from the hospital to the head of department, that's done as an emergency care plan in any event. And then from him to other people in the department, each person responsible for teams with lists of updated names. I'm saying this because on the one hand, it's one of those things that seems completely obvious. On the other hand, you have to keep updating these things, because then what you find is we just recently did ours, having only looked at it a year ago, to discover that the staff changeover in that year is enough that you have to start all over again. And these things have to be done, because the last thing you need is in the middle of this crisis to be trying to find people's phone numbers and find out where they are. It's generally chaos. It's organized chaos, but it's a very different environment for doing clinical work or any type of environment intervention. That's important. One of the first things I've learned is A, to shut curtains, and B, to throw out journalists. My assertiveness has increased over the time. People tend to feel that they are allowed to come in. It's a news event. We've spent a lot of our time convincing them otherwise. The other thing that we've done, not always successfully, I have to say, is that our emergency rooms, like I assume many around the world, have large flat screen televisions on. When an event happens, then that tends to be the news, and that's the only thing that's on. One of the only factors that we know that 100% predicts PTSD is watching those images afterwards, so we go and find the off switch. Again, that's not always very popular, but it's important. And we know a little bit about what's called psychological first aid. It's evidence-informed rather than evidence-based. And it's a lot of very good common sense things that we ought to be doing to help people. Making sure that they're safe and making sure that they have somewhere to go, and providing initial contact and support. Making sure that people are linked. And I think that definitely helps organize what we see in the beginning. However, the assumption is that most people are going to be fine. It's only a very small percentage are going to, any symptoms that you see are not going to reflect psychopathology. That's definitely true. However, our experience showed us that there is a small percentage of people who in those first hours do express extreme symptoms, and that should not be ignored. It's generally not a good sign. So it's very difficult when you talk about these initial reactions. There's no DSM to look at. There's very, very, very little data in general. We know that it's unpredictable. Things are unstable. Symptoms go up and down. And again, not to confuse symptoms with psychopathology. However, the other aspect of this is that from our point of view, the hospital is where we work. It tends to be considered by most of the time a safe place. But for the people who are coming in, it's not. It's often part of the trauma for them. And here's a quote from a psychiatrist who works in Tel Aviv, saying that most of the survivors are halfway between enduring stress and reappraising its consequences. For them, the trauma is not over. And many, when they talk about the stories, their narratives of their traumatic event afterwards, they will include elements of what happened in the emergency room as being as part of the trauma. So it's important, I think, to be aware of that. Again, when you work there, it's a shift to understand quite how traumatic it can be, and it's something that we try and mitigate as much as possible and certainly acknowledge. In terms of adaptive reactions, well, that pretty much involves any emotion that you would like. However, the patient themselves doesn't seem to be that stressed by these emotional reactions. They seem to be able to take those in their stride. And we do see changes in the narrative even at the beginning. Now, we don't ever ask anybody, please tell us what happened to you. This links with what Chris was saying earlier about the debriefing. We would never ask somebody, but people tend to tell you, and you come back a couple of, like 20 minutes later and then an hour later, and you can already see a slight change in how they're talking about it. That's generally quite a good sign. However, on the other side, in terms of maladaptive reactions, are people who seem to have no periods of calm whatsoever. The people who are extremely dissociative, we walk in and they have no reaction to us whatsoever. They are still in the bus that's exploded. They're looking at you, but they're seeing something completely different. So we see sometimes very extreme dissociative reactions at this stage, linked to intrusions, which are extremely distressful. Social withdrawal is definitely, the person who comes in and says, no need to phone my parents. It's a really bad sign. I think this also reflects the Cyprus society. I mean, Israel's a very family-oriented society with a lot of social support. It's an extremely unusual reaction and something that would definitely worry us, as well as the inability to have any sort of reflection on what had happened. Again, these are based on our clinical experience. We have a little bit of data where we looked at people who'd come in. This is in the emergency room where we assessed them. Some people after traffic accidents, most of them, and some after a terrorist incident. I think I'm right in saying that there's only one other study that's looked at people whilst they're in the emergency room, and that was traffic accidents. So I think it's relatively rare data. And what we've got here, just where the differences are between people who come in after a traffic accident to after a terrorist attack. And what we can see is that there's not much difference in terms of physical injury. I think that probably reflects the fact that they're in the same type of emergency room. This obviously does not include the people who were rushed into surgery or somewhere else. They're more likely to have got an infusion, more likely to have stitches, less likely to see an orthopedic surgeon, again, probably reflecting the injuries that they received. They report less pain. I think that's interesting. Than the people coming in after traffic accidents. They were much, much more likely to be exposed to somebody dying or somebody being injured in their incident or having witnessed that, and significantly more likely to have been exposed to grotesque images. So that's something about the background, that they are a slightly different population. And in terms of the symptoms, then many of the symptoms when you look at immediate distress are very similar, and this just shows the where there are differences. So in terms of dissociation, then they report greater time distortion. They're more shocked. They were more sure that they were going to die. They felt that it would never end, and their level of difficulty in general is much higher. However, there's lower levels of helplessness, which is interesting. I think it may reflect the fact that after a major incident, then you're much more likely to be brought to the hospital by an ambulance than you are after a traffic accident, depending on the severity, in terms of level of severity of injury. And this reflects also the types of injuries that we were seeing maybe 10, 15 years ago, that after a blast injury, then by definition, everybody is scooped and taken to the hospital, even if you can't see any external injuries, because there's always a danger that there are internal injuries that you can't see or problems with hearing. Whereas after a traffic accident, if you look okay, you're more likely to need to go to the hospital by yourself. So that might be reflective. And I wonder whether also that the lack of, or not the lack of, the feeling the report of less pain is related to the dissociation. They're more dissociative, but they feel less pain, and those would go together. So that's the very little bit that we know about these initial reactions. In terms of research, looking at when you do intervention, what actually helps, well, there's very, very little out there. This is something from Tel Aviv, a non-RCT, where whoever happened to be around gave some sort of intervention in the emergency room, and at follow-up, there was no difference between those who'd got it and those who hadn't. Similarly, this is a group from Hadassah, some who got benzodiazepines. Again, it wasn't an RCT, and the people who received the benzodiazepines were doing worse at follow-up, but it's a very small sample and not clear how seriously that needs to be taken into account. Again, these are children from the Hadassah hospitals, again, who'd seen a mental health professional in the emergency room, followed up, no difference between those who did and those who didn't. And another example is the work of Yori Gidron, trying to help people restructure their memory in the first 24 hours after the event. Again, not with very many positive results, which led to a conclusion a few years ago that there really is nothing that's proven efficient at helping in those first few hours. So that's, I think, a cautionary note that we go in and that we do things, but we're very unsure what it is we ought to be doing and whether that has any effect either short-term or long-term. More recently, since that statement was made, Barbara Rothbaum's published a paper looking at a modified type of prolonged exposure in the emergency room with more positive results. So it's possible that there are still things that we can be doing in those first hours that will help in the long term, but at the moment, we don't know. So that's where we are for the first number of hours. Now, in terms of the work that's been done in interventions in the first number of days, I'm not really going to talk very much because it's the same, I'm just repeating the same message that we've heard earlier, which is that when we're talking about debriefing, then the studies show either nothing happened, it made no difference, or one or two studies showing that it might even make things worse. So here's just a nice table that you can quickly read through. People do like it. They really do like debriefing. I can send you the slides if you want to look at every single study slowly. But people do like it, and I think that there are still questions that remain regarding what we're trying to do here, because if we're trying to prevent PTSD, it probably isn't the answer. But if we were talking about, that's initial symptom reduction and quality of life, well, there may still be things there that are important, and I think we haven't explored a lot of those to the end with those aims in mind. But I'm going to talk mostly about, I think you can see this here, first weeks. We started a study 12 and a half years ago now, in the midst of many terrorist attacks going off, with the feeling that people were falling through the loops. We weren't catching the right people. They weren't getting the treatment that they needed. And we were concerned how to do that in a way that reflected good clinical practice as opposed to good research practice. I'm saying this very carefully, but there were not many, but there were RCTs that were very clean and very nice, and most of the therapists that we work with said that's very nice, but that does not reflect what I'm doing in my daily practice, and we wanted to be able to have a look at this. And we also were aware that, having done many studies when we followed up whole populations, that when you start doing an RCT, then you miss out a whole load of people who don't get into your RCT, who are very relevant, and we wanted to understand a little bit about this. So, this is the Jerusalem Trauma Outreach and Prevention Study, and it was an outreach study, first of all, a long-term, longitudinal follow-up study with an embedded RCT. So the people who got treatment within this long-term outreach, enabling us, hopefully, to follow a whole population and see what happened to them. And we wanted to know whether early intervention helped prevent PTSD, which therapy worked best, and whether there was a difference between providing early treatment versus not so early treatment, and how effective this was. in general. So this is all of our ER admissions over a period of 5 years. And what we did was that 2 weeks we telephoned them. We had a group of people doing outreach telephone interviews. And we asked them pretty much everything on DSM, plus a whole load of other things. Anybody who reported that they had not had a DSM-A, this was still back in DSM-4, 12 years ago, who had not had a criteria, they hadn't had an objectively and subjectively sufficient event, then they were thanked for their time. I'll talk a little bit more about them in a minute. And anybody who was symptomatic, and we were as inclusive as we possibly could be, then they were asked to come for a clinical interview approximately 3 weeks after the event. And at that point, there was a clinical interview with a skid and CAPS and a whole bunch of questionnaires to see how people were doing. And at that point, anyone who was symptomatic with PTSD and who didn't fulfill our exclusion criteria, which we kept as minimal as we possibly could, then they were invited to start the RCT, which was treatment began at 4 weeks post-event. I'll talk a little bit about what we actually checked in a minute. Everybody was followed up at the end of treatment. Treatment was 3 months, so at 5 months post-event, everybody was followed up. Some people had not received treatment in the first round because they were in the control group. If they were symptomatic at the second time, then they got prolonged exposure as a late treatment. And telephone interviews to everybody came at 7 months. And then we did another clinical interview at 8 months and a fourth clinical interview at 3 years. So everybody who was interviewed initially by telephone was followed up. And anybody who was initially came for a clinical interview, whether or not they went into the RCT for whatever reason, was also followed up at 8 months and 3 years. So in this way, we were able to follow a whole population. We also followed some of those people, 10%, a random 10% of those people at the beginning who'd said, no, I didn't have a trauma. We also checked on some of those and how they were doing. In the RCT, we had 5 conditions. People either received prolonged exposure or they received cognitive therapy, which allowed, it was trauma-focused CBT without any type of exposure at all. Both of these have been shown to be effective with chronic PTSD, and so we wanted to check both of them. Short-term PTSD, and it's important also that this was 12 sessions of treatment, which is relatively unusual at the time for early interventions because most people were giving shorter 5-session interventions. This was 12. We wanted to make sure that there was the full impact. SSRI or placebo, it was a double blind, and some people got waitlist control. We did something called equipoise stratified randomization, which of course you'll know what it is. As I said before, we wanted to reflect clinical practice, and most clinical practices, when you come along and they say, we want to give you medication, then you are able to say, no, I don't want that. I'd like to see the psychologist instead. And so this type of randomization allows for people to refuse up to 2 conditions and then become re-randomized into the trial. So in that respect, you get a better sense of what people want, but you also don't lose this feeling of, what's actually going to happen clinically. And we were as open as we could be to allowing people to move without the protocol as much as we could. So what did we find? Well, firstly, let's just look at the numbers. More than 8,000 people over that period. Again, this is obviously there were more than 8,000 who the computer said this is somebody who's had some sort of traumatic event. We tried to call more than 5,000 of them. We managed to talk to more than 4,000. 6% refusal. This also reflects what Chris said before. People are delighted when you phone. We have an excellent team, but they really, 94% acceptance rate is very, very, very high. We did full interviews on nearly 2,000. That means the other people were the people who hadn't had a traumatic event. For example, the person, and this is a true story, who had opened their fridge and freezer, I'm sorry. They'd opened their freezer and a frozen chicken had hit them on the head. And they didn't end up in the emergency room. And we said, okay, not exactly what we were thinking about, so, but thank you for your time. So we invited nearly 1,500 for a clinical interview. 700 or so turned up. That's quite important, and I will return to that later. And invited for treatment were 397. Actually, attended treatment were 289. These numbers are important, and we'll come back to them. But we've gone from 8,000 admissions to under 300 who've actually entered early treatment. And what did we find? So in terms of whether early intervention prevents PTSD and which therapy works best, then what we can see here is that prolonged exposure and cognitive therapy work beautifully. That's these, okay? They're exactly the same all the way through. It's not just the outcome, and they work very nicely. Whereas SSRI, placebo, and waitlist control, all exactly the same. So that's a nice, clear conclusion that the psychological therapies work very nicely, whereas the others do not. In terms of, you can hear the cynicism, maybe we'll come back to this. In terms of early versus late, this was very surprising to us, and I think is very, very important and has many implications. And again, we'll come back to it again in a bit later on. But this is how everybody started off. This is after these people had got treatment, okay, and these people hadn't got treatment because they were in the control. So this is at 5 months, and you can see a significant difference. But at the end of the day, at 8 months, when everybody had got treatment, they end up in the same place. So that's very important. You can do treatment at 1 month or treatment at 4 months, and you end up at the same place. Okay? And I think that's very important. The other thing that we found, which is again has many implications, is that these are the people who had full PTSD at the beginning. I said we were very inclusive. That meant that obviously PTSD, you need a month of symptoms, so these people didn't quite have PTSD. They had PTSD minus the time factor. But we had people who had full PTSD apart from that in terms of symptoms, and some people who didn't have full PTSD, but either the assessor said they need treatment or the patient themselves says, I need treatment. So we have two groups here. Some people have full PTSD and some who don't. So these are people who had full PTSD on the wait list, and these are people who had full PTSD and got treatment, the treatments that worked, prolonged exposure and cognitive therapy. And what you can see is a nice significant difference between where they end up. Okay, so that just reflects what I said before. And now we have those people who had partial PTSD. They had symptoms, wanted treatment. These are the people on the wait list, so they didn't receive treatment. And these are the people who did receive treatment. No difference. Now, this is really important because it means that the person themselves, the individual, might be saying, take me, I need something. The clinician might be worried about them, but if they haven't got the full complement of PTSD symptoms, it's actually not worth doing the treatment. The natural recovery works just as well. So that's only if you have partial PTSD. If full PTSD, you see a different group. Okay. So in terms of all the studies that we know about, we know that when you take everybody, regardless of symptoms at the beginning, then you don't get many effects. A different group of studies have looked at people who are symptomatic, and definitely you show that trauma-focused CBT is more effective than other types in this group. But really, the group that are most important are those people who actually have or acute stress disorder, PTSD, without the time frame, and then you actually see effect sizes that are worth repeating. Sorry, it says the same thing, you can't see what it is in red, but basically there's very little evidence to show it's worth doing interventions for most people. It's only for those people who have full PTSD. However, in general, there's not much evidence out there, and I think it's important to know that. There's two conclusions here. One is evidence supporting the effectiveness of most interventions used to prevent PTSD is lacking. A very recent review article has also said that it's scarce. I think, it's important to know that we have a little data out there. Much of it shows that when you do these early interventions with the best intentions, if you don't pick your people, then it's really not worth doing. And even when you do pick your people, then the sizes are not enormous. So, what does all of this mean in terms of service planning? What should we be providing following a terrorist attack? I think that there's a general feeling that there are unmet needs. I think, Chris talked about this, and I think that there's a general feeling through the literature that even when you provide lots and lots and lots of money, then that doesn't necessarily help. And I think that there's a perception that of four elements. Firstly, that the focus is PTSD. That's certainly in terms of the research. That's where you see the focus. That existing services cannot cope with large disasters. That there's an urgent need to treat, and that outreach is key. That's how you need to go about it. So I want to look at all these, each one with maybe slightly different conclusions than most people have, but it's based on the experience that we're having, certainly at the moment, and some more data that I'll bring from that large study. It may not replicate. Now, what I'm saying may be accurate for where we are in Israel, with ongoing terror of a slightly different type. It may not be relevant, but I think that the experience in any event is important because the questions are important. So in terms of PTSD as the focus, then this is from our large study of, this is 750 people who came for the 2 weeks after the event. Now, we were surprised at the levels of other things. Now, we knew that it would happen, but the levels are very, very, very high. We're talking about nearly 40% with major depressive disorder and almost 20% with a different type of anxiety disorder. Clearly, PTSD was, what most people had, but these disorders were very, very important for many people, and this was different, I think, to what Chris, what you mentioned earlier. These were new. This wasn't that they were pre-existing and we just happened to pick them up, but these were new since the event. That was the first thing. The second thing is that these were all of sufficient level that they required treatment in and of their own right. So it wasn't that they were secondary to the PTSD. These were people who were so suffering with whatever anxiety disorder or depression that required primary treatment. And we were surprised by the level, I'll say it again, and I think it's important when planning services that we talk a lot about having specialized trauma therapists, but it's also very important to have general mental health services that can deal with a range of psychiatric disorders after a big event. I think that it's something that's often missed, and these people are often really suffering, and just because it's not PTSD doesn't mean we shouldn't be aware. In the recent spate of attacks that we've had, one person really worried the social workers who saw her in the emergency department. We assessed her really very quickly, and she was indeed suffering, but it was nothing to, it wasn't nothing to do with the trauma, but PTSD was absolutely not the focus, and she was referred out with the trauma service for her treatment, and she's not alone. And I think these data are very important. I assume that they're not unique to our population. Substance abuse is very low. That is cultural. I assume that would actually be higher in other places. Existing services can't cope. Well, let's have a look. We were really worried about this. When we started doing the study, I can still remember the conversation where we said, we cannot possibly do this. We don't have enough therapists. It's not okay, because we're going to have all of these people, we're going to be flooded, and we simply don't have enough therapists. So when you look at each 100 people who come to the emergency room after a traumatic event, how many of them actually need treatment for PTSD and come for that treatment? So when we looked at everybody in our study, then we see it's 14.5%. And when we looked at the people after terrorist attacks, we assumed that would be slightly different. Well, it was slightly different, 16%, not massively different. So this is something that's really important in terms of that worry about being overwhelmed. is that a lot of resources need to be put into doing outreach, and we'll come to that in a minute. But when you actually do it and you still try to provide free treatment that's convenient for people in the first month following a traumatic event, very few actually come. And that's quite important. Now, we were able to replicate this a couple of times in real life situations rather than research, which is not always the same. In a couple of years, towards the end of all these terrorist attacks, then there's something called the National Insurance Institute in Israel that pays for treatment for trauma victims, for terror victims. It used to be a very complicated system that you had to go and prove that you were you'd been exposed to a certain event, and only after months of argument you got your pieces of paper through and were able to get treatment. So we often treated people for free. And so they changed everything, and they said now if you come to an emergency room or any other type of immediate mental health facility that have been set up, then that's it, you're registered. And we get automatic funding for doing systematic outreach and initial treatment. And it's only if the initial treatment isn't sufficient that they have to go through the bureaucracy. Between 2006, when this was implemented, and 3 or 4 months ago, we rarely had to use this because there've been, as I said, a great reduction in the number of terror attacks. But in 2008, there was one, and so we followed up everybody who came in using this, doing systematic outreach. And sorry, that's the event. It was a tractor event. And what we see is, again, 14.8%. It hasn't changed very much in terms of everybody who comes in, how many actually enter treatment early. So in terms of what that means to your patient flow, it's not again, it depends on how many people have actually come in. It's a percentage, but it's generally workable with. We've generally found that you're able to, certainly in terms of treatment, you're able to provide that within services that are available. Now, I know that's very different to many of the messages that you heard earlier, and I think we'll hear later, but our experience is that it's so difficult to actually get these people in, and many of them are doing okay anyhow, that you don't require more therapists. What's been happening since then, in the last 3 months, we've had over 100 admissions over the period of the 3 months. It's slightly different because the admissions are ongoing. I think that planning has to be very different to when you have one very, very large event to many little events. In some ways, the many little events is easier. It more reflects what goes on a general basis, but sometimes it can be harder because people get more burnt out. It's very difficult to maintain this over 3.5 months. I have many problems with that with my staff. Again, we were using the same program in terms of systematic outreach, and that includes a telephone interview a couple of weeks after the event, a clinical interview after that if needed, and then 12 weeks of therapy. This is the first time I think I've ever had a slide with different types of terror attacks, which is a little bit shocking to me. But what we can see here is that most people are coming in after stabbings, but some people are coming in after what's called driving. A driving attack is where somebody takes their car and rams it into a whole load of people, shooting, stoning, and a few others. So most of them are stabbing. And most, 50% pretty much, men and women. Most of them only remained in the emergency room. Very few were hospitalized. I have less data over those who were hospitalized, so some of them were very severely injured and are still unable to communicate. And when we attempted to do the initial phone contact, then these numbers are much bigger than we're used to, and so we were using many people who were working in a general mental health clinic as opposed to any type of trauma clinic. We discovered a couple of things that have been new and are important, I think, in terms of planning. The first is we had a relatively high percentage of people with no telephone number. This is really unusual because in Israel, every single person is attached to their phone 24 hours a day. The numbers are much higher than pretty much anywhere else. So that 11% is very surprising to us, as is the fact that there's so many people that we couldn't get hold of. We're still trying to figure out exactly why. As I said, this is quite unusual. Only a few people didn't want to talk to us. It's the same percentage as before, so that's good. Another 8% had a different type of problem, so they weren't interested in talking to us, but they did need mental health help. 6% were already in therapy and didn't require or want anything else. With some, we're still not quite got hold of, but we still will be. And nearly 20% were symptomatic and did need following up. Nearly 30% were feeling fine. And I think that's really important. So there's a lot of resources here, but many, many, many people said, it's nice that you phoned, but thanks, bye. I think in terms of what Chris was saying earlier, I think it's interesting. We don't have anything in place to follow those people up from your data than we should be, because they may become symptomatic. There's no funding in place at the moment, but we'll see how we can do that. So a relatively small percentage of people actually wanted to come in, actually needed to come in. In terms of that there's an urgent need to treat, I'm going to bring some pretty depressing data now. And I'm being pretty serious. So this is what we saw before, that there's no difference between early and late. And that was quite reassuring, I think, because I felt that, I run a CBT service that doesn't just provide services to trauma patients. This meant that, if I have people who have got depression who are very urgent, I can with a very, I can calmly say to the people with PTSD, if you wait another couple of weeks, nothing will happen. I know nothing will happen. But then we did our 3-year follow-up. This just shows you who came in. Most people were followed up, but we also followed the people who didn't come into our trial at all. And that's important because we don't know very much about these people generally. The people who say, no, thank you, don't want to talk to you, don't want to come to Hadassah, don't want anything, it's important. These are the levels of PTSD at 3 years, depending on the group. There are no significant differences between the groups. This is depression. Again, there's no significant differences between the groups. And you can most easily see that here. This is 3 years. So everybody starts off here. Some of them got treatment and did much better initially. But at 3 years, everybody ends up at the same place. Again, I'll say what I just said. These are pretty depressing data, but I think they're very, very important. They clearly need to be replicated in different places and different times, and But I think they're pretty robust, and it means that we have to start, I think, looking again at how we plan these things and what we look at and what we're trying to attempt. One argument is to say that initial bit, that's really important for quality of life. It doesn't mean you shouldn't treat, because at least they didn't have PTSD for all those months, and that makes a big effect on everything. We know that when you have PTSD, you use more health services, you're more likely to get divorced, you're more likely to be unemployed. It has a whole host of other issues. So it's not to say don't do this, but don't necessarily expect that over the long term that's actually going to make a difference. And the other way that we looked at this data was to look at it completely differently and look at trajectories. And what we found here, this sort of follows on from the slide that, of banana that Chris brought, but it's important, is that you have some people who are rapid remitting. Most people get better. Some people are slow, and some people never seem to get better. Now, what we discovered is that if you were in a slow-remitting group, but you got prolonged exposure or cognitive therapy, then you swapped and you got better. You sort of moved into a different group. But there doesn't seem to be anything that affected that non-remitting group. And I think, again, these data are really important. They're connected to the previous slide, which is that for some people, you don't need to do anything, and they're going to get better, and that's the majority. Even if they look like they need your help, they probably don't. For those people in the slow-remitting group, they're nearly a third of people, then yeah, it's going to help. But there are some people for whom you're going to provide the right services from the very, very, very beginning, and it's going to make no difference whatsoever. In terms of outreach, I want to say something about our team. We had an ideal situation. We were funded by the NIH. So we had money to pay people, we had incredibly dedicated, very highly trained, very, very good people working in outreach. Anybody who wasn't good did not get to stay on the team. And I'm being very serious about this. It doesn't work if you have the wrong people. It requires a certain level of, a certain skill set not everybody has. They also could work in the evenings, for example, when people are more likely to answer the phone. They could back each other up. So somebody, said, I can't talk just now. Oh, my colleague will phone you a bit later. They worked as a team very nicely. They didn't have competing demands. Nobody was saying to them, but there's a patient waiting to see you and you haven't seen, enough patients this week. And we had wonderful accommodation off campus. Hadassah Hospital is very difficult to get to, and when you get there, there's nowhere to park. And we had... These things are actually quite important when you're trying to plan these types of services. And we had an apartment in the center of town, absolutely beautiful, completely central. We had ideal situations. And even with ideal situations, then only 50% of people actually came to the initial clinical interview, and only 4% actually took up treatment. So there's something about systematic outreach, even under ideal situations, that doesn't necessarily get you where you want to be. I think that 50% is very worrying because those other people are really falling through the cracks. We've got the same now. For the people who we interviewed for a clinical interview, then we're at pretty much the same levels. 46% have not attended. So, what are our conclusions in the meantime? Firstly, I think we have to be careful about what we're trying to achieve. I think we have to be very clear on goals. I think it's important to try and understand why prevention or providing those early treatments is so attractive. There's something that's slightly unusual about it. Why is it that after terrorist attacks or mass disasters we do, but after other events which are more common and they cause PTSD as well, we don't feel the same need to do that intervention. I think that certainly what's true where I come from, then therapists do want to do something. They want to be able to help the situation somehow, and I think that's important on the one hand, but it needs to be assessed on the other. Certainly that there's research showing that there are windows of opportunity in terms of intervention, so that might be a reason why we need to be carrying on looking at this. But interesting about why we're so interested in doing this. It's possible that we don't have any clear conclusions. I think that we need to do a lot more research and have a lot more data in order to be able to say more things in a more definitive way. We certainly don't know very much about very, very early responses in those first hours. There's not enough data. In the initial days, then we can say something about debriefing, but we still have other questions. And there's still there's lots of problems in terms of our definitions about timings and populations. We're not sure on the best dose of CBT to give, the best timing, the intensity. And the last point there, I think I've put it separately, is barriers to care. I think it's obvious to all of us that there's a large that unmet need is now much more to do with the fact that people are not coming to the services that we're providing, even when we're providing the top things that we possibly could be. So even when you're providing the best systematic outreach and free treatment that's available to people, they're still not coming. And so I think that anything that we can be doing to try and break down those barriers of care is probably the next barrier, the next most important thing that we can be doing. We're looking into different modes of delivering treatment, maybe by internet, maybe by telephone, different ways of being able to contact with people. I think all these things are very important because otherwise all we're doing is we're spending a lot of resources, and they really are, it's an incredible amount of resources to do systematic outreach without actually being able to reach those people who might most need it. Thank you.
Thank you, Sarah, for your presentation. Very informative.
Thank you.
Now we have a few minutes for questions. So right now, otherwise we'll do them later in the afternoon.
Thank you, Sarah. So much information and so wonderful studies. I just have a small question. Those with intensive symptoms right away that you talked about in the emergency room, I think we've seen quite a few of them with, you know, intensive, prolonged fear, dissociation, especially those in hospitalized after the terrorist attack. Have any suggestion what we could do further on to try to pick them out? Maybe there's something special we need to do with them, even though early intervention doesn't seem to change anything for the whole group.
Okay, I have two answers, or two parts of an answer. The first is that we try and provide something in the emergency room for them, providing them with grounding and other techniques to help them with their dissociation. That's the first part of the answer. I don't have a good answer for the others. I suspect that they're the non-remitting people. Certainly anecdotally, I can think of a number of patients that we've seen in the emergency room. They've been given the right care from the beginning, from the best people, and 3-4 years on, sometimes more, they're still with PTSD. I wonder whether that the conceptualization with ICD-11 of complex trauma, even after one event, actually answers to some of this, that they look different to us. They're reacting slightly differently. They have many somatic complaints, and they're dissociative, and they have PTSD. They look and feel like complex trauma to us, and we're trying to treat them as such. I think it's just that the definitions are less clear. So I'm not sure that we're going to be able to do anything very early on for them apart from identify them, but I think maybe the treatment that we provide needs to be non-standardized treatment for PTSD, and we need to look at them slightly differently.
Okay, I also have one question. It's about the windows of opportunity. You told us that it didn't matter if it was 1 or 3 months before you started the treatment, but do you think that there is a window of opportunity? So could you wait 6 months or 9 months or 1 year?
I don't.
And still have the same outcome?
I mean, the 3-year data would suggest yes. Again, I think if you have all the resources in the world, then obviously it's going to be better to do it quicker because of everything else that PTSD entails. But no, there doesn't. Contrary to many other studies, then it doesn't seem to be that if you treat people later, it's going to make a long-term difference. But again, I think it needs to be replicated to check it's not just this particular population.
Okay, thank you.